Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Dr. Tauseef Ali. Dr. Ali is the Medical Executive Director of Saints Digestive Institute and the Director of the IBD Clinical and Research Program at SSM Health St. Anthony Hospital. He is also a Clinical Assistant Professor of Medicine at the University of Oklahoma in the Digestive Disease and Nutrition section and adjunct faculty at Oklahoma State University. He's also on the board of the South Asian IBD Alliance and is their lead for professional outreach and education. We talked to him about his activities in SIA. We talked to him about building an integrated care model and how you fund that. We talked to him about his second edition of his book, IBD for Dummies. And we talked to him about how active he is on Twitter. Cheers.
Hello, everybody. Welcome to Bowel Moments. This is Robin.
Hey guys, this is Alicia, and we are really delighted to be joined by Dr. Tauseef Ali. And Dr. Ali, we're going to give you a chance to tell us more about yourself in just a moment, but we start out every podcast by asking the very unprofessional question of what are you drinking?
Okay, well, thank you for having me tonight. It's my pleasure. And what I'm drinking, most of the time when I come home, I'm really tired. So my wife makes me an Indian tea, which is a tea with milk in it. It's kind of like a milk tea. So I'm just having sips of milk tea.
That sounds lovely. What are the other flavors in there? Is it a black tea?
Yeah, it's kind of black tea, but it's a special tea. The tea leaves are from Sri Lanka. So you can actually buy them from an Indian grocery stores in America. And then you just use those tea bags, and they're kind of like black tea leaves. And then you just boil it and put some milk in it and a little bit of sugar, and you just take some sips.
It does sound lovely.
Yeah,
sounds very lovely.
Very soothing. It gives you some good relaxation and soothe from all the
cares
daily
of your
activities.
Day.
Yeah,
that's nice. I like that. Plus, it's nice that your wife makes it and has it ready for you. That's very sweet.
Yeah, that has a special taste, right? So
yes, of course.
Put some love in it.
Exactly.
It's better with love.
Yeah.
Robin, what about you?
I am drinking a little vodka spiked lemonade.
Oh, that sounds very good too.
Yeah.
I got real excited. My neighbor and I were talking about cocktails and she suggested a basil gin gimlet, which I don't really know what it is. I haven't even tried it yet. So I'm very excited to try it. And it looks a little funky with like my leaves hanging in there. So, but should be good.
Let us know by the end. How did it go?
I will. I did this the other day where
You're still talking to us.
Well, if I stopped drinking it, maybe it wasn't good, but I did this the other day where I was like, oh, I'm going to make myself a martini. I'm going to be so sophisticated. And so I made a martini and realized, I am not a martini drinker. So, everything is worth a try, perhaps once, but not again. Well, Dr. Ali, again, thank you so much for joining us. We're real excited to talk to you, and we have lots of things to talk to you about. But first off, tell us what brought you into our IBD community. Why did you choose IBD as your specialty?
Yeah, that's a very interesting question. And I was just thinking about it, like when people ask me this question, why did you choose IBD? Well, before IBD, a lot of people ask, why did you become a gastroenterologist? Some people say, you're a poop doctor. So, but, for me, I describe being in gastroenterology and then in inflammatory bowel disease as kind of like different phases that led me to this, from challenge to passion to mission to vision. So when I came to United States, I was challenged that I cannot go into a gastroenterology fellowship because a very competitive fellowship, and typically foreign medical grads do not enter into this fellowship. And I just took it as a challenge. So when I joined gastroenterology fellowship, inflammatory bowel disease was very intriguing because the state where I was getting training, in the state of Oklahoma, we had only one person who was inflammatory bowel disease trained. And I saw how fascinating it was because it kind of encompassed a lot of specialties: immunology, infectious disease, rheumatology, basic sciences, inflammatory pathways, your pathology, your research, your trial. So it was very intriguing. So I just took it as a challenge. And then that challenge became a passion of mine. And then with that, I just had a mission that you know what, I'm going to just dedicate my career, my life to take care of IBD patient. And with that vision, then I thought I'm going to establish our first state first inflammatory bowel disease center of excellence. So that's my little story.
That's phenomenal. And you were with a state institution at that point, correct?
Yes, so I
Okay.
received my training at University of Oklahoma. I did my fellowship there. I went to University of Chicago to receive training in inflammatory bowel disease under the supervision and mentorship of Dr. David Rubin. Came back and we started our state first IBD Center of Excellence, first in an academic institution. And then in 2014, I moved to a healthcare system, SSM Health, where I have been establishing and creating this IBD Center of Excellence.
Can you tell us more about what is encompassed in a center of excellence? What do you need to have in place in order for you to be able to call yourself a center of excellence?
This is a great question. When we talk about center of excellence program, there's a little bit of ambiguity in these terms. But basically what it means is providing an integrated care model to patients suffering from chronic illnesses. And inflammatory bowel disease is one of those chronic illnesses where patients have this suffering and this illness for quite some time. And not only there is a delay in their diagnosis, but they have this most of the time a rough course in the beginning with their flares, and then they need to be maintained on medications, and then they get complications, they get side effects from medications, and we talk about surgery. So it's a chronic illness. In order to take care of patients with a chronic illness, you really need to have an integrated model where your primary care physician, where your specialists, different specialties such as gastroenterology, surgery, rheumatology, infectious disease, dermatology, urogynecology, gynecology. It needs to be an integrated model where all your physicians from different specialists come together. Not only physicians, but then your nursing support, your ancillary support, your research and clinical trial support, your staffing support. It all needs to be integrated so that you can provide comprehensive, best care for better outcomes. So that's called integrated model or a center or a program. So once you achieve that, that helps you take care of your patients in a better way with better outcomes.
So do your patients have to enroll in a program to be a patient of this? Like, do you have patients that are part of this center and patients that are not? Or are all of your IBD patients, like in the Center of Excellence, considered part of the program? Does that make sense, what I just said?
It does make
Okay.
sense, and it actually raises an important question and an important thing for our listeners to understand that also, like, well, how does an integrated model or how does centers work? So there are different models in the United States about programs and centers, but typically it is run by, the IBD centers are run by IBD physicians. So for example, in our center, I run the center. So all IBD patients, all patients with the diagnosis of Crohn's disease and ulcerative colitis, when they come to us, they are part of this medical home. They're part of this integrated model, which means, for example, I'll just walk you through the process when a new patient comes to my clinic. So when they come to my clinic, first of all, they receive a phone call from the nurse, and the nurse get the information, make sure that the patient is ready for their first interview. Then during the interview, we talk about management plans. Then they get to meet with our staff, from schedulers, from the coordinators, biologic coordinators, medication coordinators, pharmacists, dietitian, therapist. If they need to see a surgeon, they will meet with the surgeon. If in future they need to see a dermatologist, rheumatologist, we have them available, and we have an open line of communication with them so that the patient does not have to struggle finding, okay, who I'm going to go see a dermatologist, who's in my plan, and or what I need to do. Do I need to make those appointments myself? We take that responsibility so that we provide them an optimum care. And not only that, if the patient is flaring up, they need to go to the emergency room, they need to get admitted to the hospital. Everything is streamlined, everything has been pre-worked for them, so they don't have to go through the hassle of like explaining everything to everyone, and it's all get taken care of. So that's kind of like the model. So by default, any patient who comes to a center, to any integrated model or any program like this, they typically are taken care of by this comprehensive team, either right from the beginning or as the need arises. So they don't have to struggle. We take care, we hold their hand and become their partner in their journey of their illness.
That's really great. We had Dr. Tim Ritter, who's part of GI Alliance, was talking about their model as well. It sounds very similar, where you're right, but in theirs, they can enroll patients into it. It isn't automatic like you're talking about. I'm curious, when you were doing this back at OU, because one of the other guests we had on is Dr. Jean Tung, who's at OU Children's. And I'm curious, how did you integrate? Were you able to integrate the OU Children's sort of automatically transitioning into that integrated program at OU at that time?
Yeah, so going back to the one additional information. So when it comes to enrollment, basically those enrollments come to, there are two areas where patients are quote unquote enrolled. One is if they are part of a registry or a part of a platform where all their information is shared. So we are part of what we call IBD Chorus. So it's where patients participate and we look at our benchmarks, quality matrices. But then there is an enrollment for clinical trials. So these patients, if they want to get enrolled in clinical trials, if they want to get enrolled into get newer medications through clinical trials, then there is an enrollment for that. But since we are a very dedicated Crohn's and colitis center, so when we get the patient, they are just part of our Crohn's and colitis center. In terms of collaboration, yes, we have collaboration with not only when it comes to transition of care, we have collaboration with our colorectal surgeons. As you know, that these patients need a very specialized surgeons to take care of them when it times for their surgery. So if you do not have a colorectal surgery program, then you depend on your nearby colorectal surgeons so that you have a very strong collaboration. So we have that strong collaboration. And talking about children's and their transition of care, we have a very strong collaboration at two levels. One is more a research level where Dr. Jean Tung, who is our pediatric IBD expert in the state of Oklahoma. So we have a collaboration through research program where we are studying the transition of care and the outcomes when you have a very well-structured program. So outside that, yes, we have other collaborative lines of communication where we have a dedicated nurse and they have a dedicated staff that we can talk about transitioning of a kid who wants to come to our clinic. So we are well prepared before their arrival. We get not only medical records, we also get a review from physician, from the nurse who has been taking care of them for a long time, sometimes 16, 15 years. And they're very close to them. They're like part of their family. So now we are getting all that information to us. So Dr. Jean Tung and her team does a really good job where we have developed a mechanism where not only we are getting medical records and information, we're also getting perspectives about their personality, their families. So we get introduced to them before their visit. And when they come and visit us, we try then our best to kind of like have least interruption in their care, as well as in the relationships that they have with their pediatric IBD team. So that's how we work very closely with OU pediatric department, as well as the community pediatric gastroenterologist who also then transition their patients to us. So we have open line of communications with them. And I think the key thing is to understand the importance of communication and the processes of transition of care, because there's no one standard way and no one standard format of transition. So it has to be individualized. So we are very lucky to work with experts like Dr. Jean Tung and other community gastroenterologists where we have developed this relationship to have a smooth transition of care.
It must be a huge relief to those families as well to see that really great integration between the two systems to be able to work together like that. I'm sure it's a huge relief for some parents that are pretty anxious for their kids. You mentioned IBD Chorus, and that is a really interesting program where they do a lot of quality care initiatives. And you mentioned that this is sort of part of looking at that in IBD Chorus. I know one of the things they do in IBD Chorus is really measure the effects of this. So they come up with an idea to figure out how is this going to improve patient care, and then they measure it and go back to each other and sort of say, how did this work? How are you measuring these integrated care models? What are your metrics that you're sort of looking at when you're putting these together?
Yes, very important question in terms of quality of care in IBD in general also. So not only there is this platform of IBD Chorus, I think in any IBD center who are even not part of IBD Chorus, the ensuring that you are providing quality care and measuring those outcomes is very critical. And so there are different ways, and it all comes to better care of your patient, which means you need to monitor how many times you are prescribing steroids to your patient, how many times your patients are landing in the urgent care and emergency rooms, how many times narcotics are being prescribed to your patients. Are you checking parameters like their anemia, making sure their vitamins are adequate, making sure that they are on their medications and have the knowledge, education, and proper training and understanding. Patient education is part. I truly believe that patient education is part of providing quality care. If you are unable to make your patient understand, if you're unable to make your patient kind of activated, where patient activation has been shown to improve outcomes, these are critical parts of being a center of excellence or being a part of providing integrated care model to the patients or to the community. So all these different outcomes, and then we are part of a healthcare system. So we are subject to different value-based, quality-based parameters that are being monitored at a system level, at a hospital level, as well as now that we are this newly established branded center, I'll be happy to talk about, but so we are measuring all these things. For example, one of the things that we have started ourselves is monitoring the time between the decision making of starting a biologic drug and what I call is DIB, which is drug in body. So when was the actual biologic was given to the patient? So what is that time interval? And with adequate staff, with adequate support system, can we decrease that interval? So if I have, for example, started a patient on an anti-TNF drug or an anti-integrin drug, and I've made that decision, my patient has made a decision, but now a lot of factors will decide how soon that patient will be able to get that medication. If it's an infusion, we are dependent on infusion center, their scheduling. We are dependent on insurance plans. We are dependent on denials and prior authorization. So there is a process that can typically take as fast as 3 days or as long as 3 months. There is no telling. So now part of being a center, part of being an integrated model, it becomes a quality parameter that you are trying to shrink that interval by having an adequate supporting staff, being an advocate for your patient, enabling your patient, having them have this understanding so they can become their own advocate. So how you can shrink that interval so the patient get their timely medication. So that's one of the main focus that at least we are doing in our practice, is to how we can be more successful in bridging this gap of a delay in the practices. And there are many other examples of providing quality measurements and measuring their outcomes.
Just from my personal experience as a patient, I appreciate being at a center and having that education, because one of the ways I advocate for myself is I know I have 2 more refills left on my biologic. So I know that it gets denied every single time we try to refill it. So 2 months in advance, I reach out to my doctor and say, hey, I know you know this, but it's time to try to refill because it's going to get denied. And, that's the only way that I can, make sure that I advocate for myself, is being proactive in that sense. And I really appreciate your work to provide that for the people in Oklahoma, because I know that it can be frustrating and exhausting. And
I have said to Alicia and even some of our other guests on this show, like, I'm just tired. I want somebody to do exactly what you said, to just take care of me, to like call me and tell me when I need an appointment, to, I need a virtual assistant to just like make my appointments for me. So when you were saying that that's what you do, it just was so refreshing to me to know that people with a chronic illness, it's just exhausting sometimes for your care. So that service, I'm sure that your patients really appreciate it. I wish it was available to more patients.
Yeah, no, I think this is again, you have touched some very critical points in the care of IBD patients, and that should be the goal of one of the goals of providing care to these patients, is to provide them this comprehensive care. And you're right. I mean, patients, they are already suffering. They're already bothered by not only worrisome symptoms, it's just affecting their quality of life. They have so much to worry about, from college, school, work, and their relationships. So whatever we can provide them to be there with them in their journey, as I said earlier, I think that's very critical. And I think that should be the baseline. That should be the minimal thing that we can do to these patients. And then I think sky is the limit. I mean, many programs, many places are limited by resources. You can't just have centers everywhere. But then it's important, it's critical for your primary care physicians, it's very critical for your patients to have that understanding that there are IBD specialists, there are Crohn's and colitis specialists around your town, in your state, where you can go and receive this comprehensive care so that your outcomes are better. And again, so that there's someone there to be available to you. And sometimes you just want to talk to someone. So you should share your information, and so that you never know. It's not only a physician who can provide you with support, help, and decision making. Sometimes it's not even sometimes, many times, I'm pleasantly surprised when my patient come and say, Dr. Ali, thank you. Your nurse was so helpful. Dr. Ali, thank you. Your staff was so helpful in resolving this issue. So you need your allies. You need a team to help these patients. And that comes with team training so that they are well trained, and also getting everyone on board in this journey.
I do think that's critical. And because you're only as good as the person who pisses somebody off, frankly. Somebody gets mad and all of a sudden they're mad at the whole team. And so, yeah, the more you can make people good at their jobs, the better. And I'm sure that doesn't happen with your team, because I know a lot of our folks that we work with are so passionate about helping patients.
I will make one comment before you ask me another question. I have told my team, especially when I get a new staff member, I tell them, these IBD patients are my babies. If you hurt them, I will hurt you.
Oh, wow. That's great.
Yeah.
I bet that's a good way to keep them in line.
Yes. Yeah.
I shouldn't say keep in mind. That's a good way to set expectations. I think perhaps that's a nice way.
Yes.
You mentioned resources. I want to stay there for just a second. One of the things we talked about with one of our other guests, Courtney Robert, who is a therapist in another center like this, where they're doing a more integrated care model. She talked about how one of the struggles for them putting their integrated care model together is getting enough funding to be able to pull in those people that maybe don't quote unquote make money for the integrated care model, people like therapists or potentially dietitians or nurse case managers, where you can't bill for the services in the same way. How did you go about that? How are you making sure you're bringing in these players in a way that you can afford, essentially? I hate to say it that way.
Yeah. No, I think this is, again, in an era where you are seeing reports of millions and billions of lost revenue from healthcare systems and practices, where the expenses are going up, the resources are becoming limited. It becomes a challenge. And I will admit that even if you have goals and vision and a dream of creating something like that, it's very hard to bring all these things into reality. So we have to admit the limitations in that. One of the ways to create these centers or integrated care model outside an academic institutions, and even I am witnessing challenges even within academic institution to sustain, from revenue point of view, from financial point of view, to sustain a model like this. But again, here are where you need your allyship. You need to make sure that your system, your healthcare system, is supportive of you. You can have a dream, you want to build an IBD center as a physician, but if you don't have a support, because there is a lot of downstream revenue that IBD patients bring to a healthcare system, whether it's labs, it's endoscopies, it's imaging studies. So you may not, from a purely revenue perspective, we are talking about not clinical care. That's excellent. That's on the top. That's our vision. That's our mission, to provide exceptional care to our patients. But we have to keep in mind the financials. If you can't sustain financially an integrated model, then it will jeopardize your vision of providing exceptional care to your patient also. So when we talk about finances, we talk about revenue, that's where the entire system has to come and support something like that. It can't be just a practice. It can't be just a specialty. You have to get everyone on board. So when you are in a healthcare system, there are already existing resources, but they're just scattered. What you need to do is to bring those scattered resources together. So you're not reinventing a new wheel, or you're not reinventing something. You're actually bringing the resources together. And where you don't have those resources, you need to find collaboration. So you can do that if you have strong allyship within your healthcare system. Because typically in a healthcare system model, I'm not talking about group practices, I'm not talking about private practices, which is a very different beast when it comes to healthcare models in our Western world, especially in the United States. When we talk about healthcare systems, I'm talking about big healthcare systems who have hospitals, who have emergency rooms, who have urgent cares. They have resources. They typically have dietitians there. They typically have ostomy nurses there. They typically have multi-specialty clinics there. They typically have therapists and behavioral medicine clinics or departments or even hospitals. Now, I have been very lucky. We have behavioral medicine hospital. We have an institution. So we have access to therapists to provide CBT, cognitive behavior therapy, and some other support system. We have dietitians within our hospital system, so we can approach them and get them there. And now we are learning that they may not be generating revenue, but there is an indirect revenue that may be coming through them. We don't have a case manager, but there's a value for that. And in near future, we're actually thinking of getting a case manager, because that's how we can reduce hospitalization, emergency room visits, and helping these patients be on insurance. So it's a very big picture when it comes to population health management at a healthcare system. Then it makes a lot of sense pulling these resources and justifying the need of these resources who may not generate direct revenue, but they will bring indirect revenue and will improve the quality of care. So it's actually a team where you need to get your higher up in administrative leaderships to be with you, and they and you are sharing the same vision. Without that, it's very difficult to create and establish a program.
Very true. We just had Tina on not long ago, and she got us in touch because she said you are very involved with SIA, which is the South Asian IBD Alliance. So I want to talk to you about that. How did you get involved with that? And it's so exciting, but tell us why you're excited about it in particular.
Yeah, well, if I start talking about this, I probably will, you both will be talking about it for 3 days, and I will not stop. So you have to tell me when to stop, okay? Because as I told you, that a challenge which became a passion and then became a mission for me. So you can see that how closely I'm connected, not mentally, but through my heart when it comes to the care of IBD patients. And then being from Pakistan, having received my medical school training from Pakistan and having to visit Pakistan to see my parents every year, I'm very connected to South Asia population. And I tell this story to everyone that how did it begin? When I was in medical school in Pakistan, I remember we had a 5-year med school program. In those 5 years, 3 years are clinical. In those 3 years of clinical rotations, I saw one Crohn's disease patient. And we were a class of 300 medical students. So when we go in batches to round on patients, I would say we were like 50 students, and we were around that patient, looking and getting fascinated that, oh, wow, we got a Crohn's patient who's been diagnosed with Crohn's disease. And now we are opening our books and looking the treatment. And this is, I'm talking about late 90s. So we were looking, oh, this patient needs to be on steroid. This patient needs to be on Imuran now. Wow, that's very fascinating. And he's getting IV steroids. Not that IBD may not be that uncommon, but people were not getting diagnosed because nobody knew about these diseases, or nobody would think about doing a colonoscopy and diagnosing them. So fast forward. So one patient, right? Fast forward 11 or 12 years ago, I actually went back, and that was my first visit to Pakistan as a faculty. I was at university, started a new IBD center. I went back. So they asked me to round as a visiting professor to their medical ward. So in Pakistan, when there is a ward, medical ward, in that ward, there will be patients, after patients laying down in beds with only curtains in between. And there will be like 100 patients in a ward, and they will be all with just separated by curtains. And I was amazed that about half of the patient in that medical ward had either ulcerative colitis or Crohn's disease. So within 11, 12 years, I saw a huge difference in the prevalence or the incidence of IBD in Pakistan. So the only difference, I joke about this, was that when I was leaving Pakistan to come to the United States, there was the first Burger King opening. And when I went back after 11 years, there was Burger King everywhere. I have nothing against Burger King, it's just an example, but it just tells you the westernization of your diet and the lifestyle. So that might have impact the incidence of IBD. So there are a lot of patients who are now being diagnosed with Crohn's and colitis there. I believe me, every time I go to give a lecture, I get lots of questions from physicians about how to take care of these IBD patients. And same was the situation in India, and same was the situation in other South Asian countries. And then not only that, there's a lot of immigrants in Western world, in United States. And I think if you look at the data, there's more than 25 million people only from India who have migrated to Western world and United States. So these patients are still culturally connected back to their home in South Asia. So the cultural competency to take care of these patients, the psychosocial barriers that we still face in taking care of these patients still exist. Tina may have elaborated that there is a challenge taking care of these patients. So that really fascinated me when Tina and we all discussed about starting this alliance. And the purpose of this alliance of SAIA, which is South Asian Inflammatory Bowel Disease Alliance, is to bridge those gaps, to bring awareness, education to the patients suffering from IBD in South Asia, to educate the physicians over there about IBD management, as well as to provide cultural competency to the physicians here in United States and in Western world, including Canada and Europe, as well as educating patients here who are South Asia origin. So that's the purpose. That's a global mission that we have embarked on ourselves. And I'm the co-director of Professional Development Committee of SAIA. So one of my job is to develop professional education programs. We are doing one program starting next month with the help of ECHO Project from United States and Parsa Foundation from Pakistan. And we are doing monthly webinars to educate general physicians as well as gastroenterologists in Pakistan. What does IBD mean? How to take care of the IBD patients? How do you diagnose them? What are the available options in terms of medical therapy, surgical therapy? And we have lined up a group of expert speakers from United States who will be educating them not only in English, but in their mother language also. Similarly, we have developed an international club, a journal club on social media to provide education to the trainees and as well as to the international audience about what's latest in IBD also. So we are also, lastly, I will tell you that we are holding our first ever symposium next year with DDW, which is one of the major gastroenterology conference in the United States. And we are bringing unique concepts that we will be talking and discussing when it comes to globalization of IBD, and especially targeting targeting our South Asian patients and physicians to develop culturally competent program to help take care of those patients, because we all now have witnessed the shift, global shift to the east when it comes to increasing incidence and prevalence of IBD. Many Asian countries, from China to Hong Kong to Japan, and now South Asian countries like Bangladesh, India, Pakistan, you're seeing a rapid rise in IBD in those countries. So that's what we are trying to achieve through SAIA, which is the South Asian IBD Alliance.
That is so exciting. And I have been so impressed with how quickly you guys have grown and how rapidly you've been able to put together this programming and being able to come up with these partnerships, like, going and doing this with DDW. I think it's just remarkable and so really obviously so necessary too. So well done. That's really exciting.
I just feel like it is so necessary, not just for, I feel like you're setting an example for other cultures as well, because there are so many that have these barriers. That when Tina was on, she was talking about like just the mindset of the family and the family making the decisions for everyone, not being an individual decision, right? And there's so many cultures that it's like that, where everything, especially medical decisions like this, is like a family decision, not the individual who's going through it. So I just feel like it's impressive, like Alicia said, so necessary, and you're opening the doors for others to be able to do that as well. I'm going to switch gears now that I'm finished gushing, because the first time that I met you, it was like 2015, I think. And we were setting up your table for your book at an education program for patients. And so you have a book that's IBD for Dummies?
Yes, you have some good memories here. I can't even remember what happened yesterday. That's amazing. But yes, so that was my first edition of my book through Wiley Publishers, their Dummies series. You may have seen those yellow black books for dummies for everything. So I wrote a book called Crohn's and Colitis for Dummies, and that was my first edition. And I'm very happy to share the news with you. Actually, you know what? I just got an email about 3 hours ago from the publishers that my book is in print shop. So I actually wrote down my second edition of Crohn's and Colitis for Dummies. And actually now you can pre-order from Amazon. So if you just type my name, Tauseef Ali, or you just type Crohn's and Colitis for Dummies, you will get that book. And I'm so excited because, as you know, so much have changed since 2013 when I was starting to write the first edition. Your definition of goals of treatment, your medical therapy, and so many aspects of life when it comes to IBD that I was so excited to write that second edition. I finished that book about a few months ago, and most of the work was done when I was traveling, going back and forth, Pakistan, visiting my parents, giving lectures. And it was just so exciting to write that book. And, every time I write something, it really helped me because I reflect what I do in my clinic. So if I'm seeing a patient having the discussion, I typically would come back, and at night, I would just write down that portion of the chapter. So kind of like so that it's very close to the patient in terms of what they actually suffer and what they actually want to discuss and what's in their mind. And the book covers from why, how I get IBD or Crohn's and colitis, what can I do, what type of diet I need to do, can I use complementary therapy, what about acupuncture, what about that herb, what about surgery, when should I have surgery, when should I not have surgery, what is an ostomy, what's the life after ostomy, intimacy, relationship issues, finding a job with IBD, going to school and college, how to work disability, how to ask for accommodation, 10 best resources in IBD that will help you, 10 myths about IBD. So I wrote down this, and I was so excited. And I'm very excited to share this news that now it's going to be available to my patients, to my friends, colleagues, and family members to read about this book and kind of like have some basic information about inflammatory bowel disease, including both Crohn's and colitis. So I'm really excited.
Congratulations. I can't believe that was your first I didn't realize like that was the first edition, and so much has changed since then.
Absolutely.
That is my
yes.
question, actually. What are some of the things that have changed really drastically, or what are some changes that you had to make in this next edition, the second edition?
Yeah, no, I think that's a good question about what has changed. I think a lot has changed from, understanding of how and why we get Crohn's and colitis, from the goals of your treatment, the approach to the patient. Why are we giving them medical therapy, and what are we measuring in terms of outcomes, just not symptoms, but some other objective markers? How we can prevent complications, how we can be smart in monitoring response to a therapy, what type of surgeries, when is the good time for surgery, when is the surgery indicated, different types of medical therapy. When I was writing my first chapter, I think there was only anti-TNF therapy available. And now, as I was mentioning earlier, we have anti-integrin, we have anti-interleukins, we have small molecules, we have JAK inhibitors, we have S1P inhibitors, we have clinical trials, we have biosimilars. So a lot has changed in terms of caring these patients. And you'll find all these being touched and discussed in my book.
Very cool. It's such a great resource. And I think people will really appreciate this updated version to feel like they're even better informed. I'm going to take you in a different direction. So when Tina was on, she very quickly said something about med Twitter. And we didn't ask her any follow-up questions because it was in the middle of lots of other conversation. But I don't know that people, if you're not on Twitter, which I'm not on Twitter, if you're not on Twitter, I don't think people really realize that this is the place where the scientists and doctors hang out. So can you explain to us about med Twitter and your activity there?
Yes. As you know, that social media has reformed our approach to a lot of things, including medicine and healthcare. Patients, public in general, we live in a social media life. I actually sometimes wonder if my kids are actually living in the real life or they live in their video games, because they know the characters of those games more than the real characters and heroes, which is another debate and another time, which I think sometimes it's an unfortunate that those have become heroes of our next generation. But having said that, going back to the social media, I think we all have smartphones. We all not only look on site, we all have different social media platforms, TikTok, Instagram, Facebook, Twitter, and we all go there to look at news, politics, fashion, but also health. A lot of people get tips from health tips now. Oh, I read about this, or this is a new medication. This is something for hair loss. This is something for acne. And so there's engagement to the social media. And what is happening in the last decade, a lot of physicians have gone to the social media also to help validate what is correct, what is incorrect, burst the myths, so that patients who are on these social medias who have been historically coming to the clinic and asking and demanding that they want this because they read or they saw a commercial, they saw this on TikTok, and this is what they want. So now, especially this next generation of physicians and healthcare providers, they have actually gone to these social media as police, and to police the social media and to filter the information. So just like others, I have chosen Twitter as a social media platform that I will be there. So I have a Twitter account called IBD Tweets, because I tweet about IBD all the time. And I actually am a founder for a hashtag respect my prescription. So it's hashtag respect my prescription. And American Medical Association actually wrote something about this hashtag not too long ago, appreciating the efforts that medical community is doing on social media to bring awareness. So for a lack of a better word, what I do with that hashtag is to publicly shame our insurance and PBMs that how these delays are ruining my patient's life and quality of life and the care and increasing the cost of the care. So if you ever want to go to Twitter and type hashtag respect my prescription, you will get all these examples of how distorted our healthcare system is. Apart from that, what I also do, I bring awareness. I share latest information about Crohn's and colitis through IBD tweets. Then I have another handle, which is called IBD Club, which is now part of SIA. And what we are doing is we are reforming that. And we have been doing these monthly journal clubs. And now it will be through the SIA platform, but it will still be IBD Club. So it's at IBD Club. And what we are doing is we are doing monthly reporting of an interesting article, especially by a trainee. In the past, we have trainee from Egypt, Saudi Arabia, Pakistan, England, United States, different states. They have all presented articles of interest, of clinical interest in that journal club. And now what we are doing is through SIA, we are also engaging a lot of trainees from Europe, from South Asia, from America to present recent article that we think can be impactful when we are taking care of our patients in clinical world, not research, not basic science, but clinical outcomes and clinical things that, so we are very excited about rolling out that program through Twitter, through IBD Club. And of course, I have a Twitter handle for my center, SSM IBD Care. So it's at SSM IBD Care. So I run 3 Twitter handles simultaneously every day. And
that's a full-time job. How do you find time to do that? Social media, one handle would be a full-time job.
It's a time management. It's a time management. And I think one of the very first things that I actually teach my kids every day, sometimes successfully, sometimes unsuccessfully, how to value time, how to value your second. I think it's important. Like it's all about time management.
I don't think you sleep, frankly. I mean, that's so much. Maybe a little bit of.
I do get my 8-hour sleep because I wrote a paper on sleep and IBD telling everyone that if you don't sleep well, you have a 2-fold higher chance of getting a flare. So sleep is very close to me. So I do sleep.
Oh gosh, that gives me at least 10 more questions to ask you, but unfortunately we are running out of time.
I told you we can talk for 3 days.
We really could. We really, really could. I think probably we have to ask you the last question though, unfortunately.
I know.
So.
Yes. This has been a great conversation. And we could ask you questions for 3 days. Alicia and I, we geek out when we have doctors on the show. So thank you so much again for agreeing to be a guest. We really appreciate how much you're willing to share with us. And we have one more thing we want to ask you to share. The last question is, what is one piece of advice that you would have for other providers who are already treating IBD, who would like to get into treating IBD? And then if you would like to throw in a piece of advice for patients, we will allow that also.
Well, thank you for that permission. No, I think this is, again, I mean, as I said, that if I have to give that message, it may stay me 3 days to keep going and keep delivering that message also. But I'll be short and concise. It will be few sentences, and it probably will be applicable to everyone, to my patients, their family members, to my colleagues, to my peers, and to other physicians and healthcare providers. You know, for the last 10 years, we have made incredible advances in our understanding of these illnesses, Crohn's and colitis. It is still true that we don't know the cause of Crohn's and colitis, although we are getting closer. It's no longer true that people diagnosed with these conditions must plan for a life of uncertainty, worrying about their next flare or complications. We have extensive, ever-growing numbers of effective and safe treatments, new methods to monitor inflammation. So I can safely say that we have officially entered the era of disease modification. So don't let your disease make you suffer. See a physician who is specializing in Crohn's and colitis. Get education, stay updated so that you can provide best care to your patient. And that's where I will end.
That is super great advice. Thank you for that. And very concise as well. I appreciate the brevity on that too. Dr. Lee, honestly, this was so fun to talk to you. Your passion is just bursting out of the screen and through your voice. And so I think anybody who gets to see you as their physician is really fortunate to have you in their lives. So thank you for that. Thank you for being an amazing physician.
I think it's probably the tea that my wife makes.
I mean, caffeine doesn't,
That is also
doesn't
different.
hurt.
Yes. Oh,
But thank you again so very much for joining us. We are so grateful to you. And so we're going to end this by saying thank you again. Thank you to our audience for joining us as usual, and cheers.
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 If you liked this episode, please rate, review, subscribe, and even better, share it with your friends. Cheers.